And tonight on A Paramedic Affair, could a standard emergency life-saving technique actually be doing more harm than good? We look at the controversy surrounding fluid replacement therapy and whether a procedure designed to save lives could actually be killing people. Fluid replacement therapy is a routine procedure for paramedics treating critically ill patients and will often be used for accident and trauma victims suffering from serious blood loss or burns, or ill patients with low blood pressure or life-threatening infections. The use of fluid in the treatment of the sick and injured can be traced back nearly 200 years when it was first used to combat outbreaks of cholera in the UK. Back then, it was proposed that an infusion of fluid directly into a patient's bloodstream could potentially reverse the severe fluid loss that might eventually kill them. The initial results were promising, and over many years, fluid therapy was refined and developed into what it is today. For the last 25 years, aggressive pre-hospital fluid administration has been a standard intervention. The idea behind fluid therapy is simple. For critically ill patients to have a better chance of survival, they need to be hemodynamically stable. This basically means they should not have too little or too much fluid in their system. Their blood pressure should be neither too high nor low, and their body should be delivering oxygen to their organs efficiently. Several things severely disrupt this stability in a patient. Excessive blood loss will dramatically reduce a patient's circulating volume, as well as decrease the amount of oxygenated blood reaching vital organs, eventually leading to a dangerous drop in blood pressure. Burns can also cause significant fluid loss, and sepsis can lead to very low blood pressure as well. The aim of fluid therapy is to restore the fluids lost by a patient with an effective substitute, and to increase low blood pressure back to a relatively normal rate. The goal is to maintain sufficient cardiac output so that organs receive adequate amounts of oxygen. Paramedics will administer fluid intravenously. Most commonly, it is simply sterile water with 0.9% sodium chloride added to it, although other types do exist. Fluid therapy sounds simple, effective, and cheap, but doing it properly is a complicated practice, and several studies have shown no conclusive evidence that modern fluid therapy is effective, or even safe. Volume overload, edema, hypothermia, and excessive bleeding are just some of the risks involved in fluid replacement therapy. Putting an excess amount of fluid into a patient can lead to edema by pushing fluid into the spaces between cells. Hypothermia can result from too much fluid being given too quickly, cooling the patient's core temperature, and resulting in heart arrhythmias and problems with clotting. Fluid therapy can also cause hemodilution. Fluids used in therapy are unable to carry oxygen, and if they dilute the existing blood too much, the body's capacity to carry oxygen around to organs is impaired. Overdilution of the bloodstream can also interfere with clotting, which can obviously be a problem when treating trauma patients. Additionally, fluid therapy has been associated with infection, increased intracranial pressure, and delays in getting patients to hospital, which makes us wonder, should our emergency services be using this at all? For more on this, we go to Danica, who's covering serious neurotrauma at South Brisbane Ambulance Station.
Thank you, James. I'm coming to you live from South Brisbane Ambulance Station tonight, where we have some interesting new research coming to light regarding fluid therapy in neurotrauma. We routinely use fluids in the pre-hospital environment for patients who have suspected neurotrauma to prevent further injury to the brain. However, evidence suggests that this can have negative consequences for our patients. I can report tonight that Bunn and colleagues show that isotonic fluid and salt administration, which is used by the Queensland Ambulance Service, in excess can cause further swelling of the brain. Now, this can result in a further rise in intracranial pressure, and this can be detrimental for our patients who are already experiencing an increased intracranial pressure caused by their initial brain injury. Now, in neurotrauma, the blood-brain barrier can be disrupted, and this causes sodium and water to leak through. Cerebral edema is exacerbated as a result of this, and administering pre-hospital fluids to these patients would contribute to this further. Now viewers, Chowdhury and colleagues and Rind and colleagues' research has consistently demonstrated that isotonic crystalloids worsen neuroinflammatory responses which occur after the brain has suffered injury. Rind and colleagues elaborate on this and state that excessive fluid resuscitation with crystalloids causes secondary complications as a result of inflammatory-mediated cellular injury and coagulopathy, to name a few. Interestingly, Rind's research also states that a key factor of neuroinflammation is rapid induction of leukocytes, which is then a key contributor to the neuropathogenesis of secondary brain injury. Now, this was demonstrated in patients who underwent fluid resuscitation with normal saline. Finally tonight, viewers, we have information coming through from Sir Ride and Deacon that clots can be dislodged and cause further bleeding into the brain, even though fluid administration increases systolic blood pressure and ensures adequate perfusion to the brain. This can have disastrous effects for our patient with respect to morbidity and mortality. And Abby has further breaking news regarding fluid therapy in blunt trauma. Abby, it's over to you.
Thank you, Danica, and welcome viewers. Although the need and benefit of pre-hospital interventions has been controversial for quite some time, an interesting amount of evidence has stirred about the administration of pre-hospital fluid in blunt and penetrative trauma patients. Providers see the subsequent administration of fluids to be standard care. The literature, however, does not support this approach, and at a minimum, pre-hospital fluid administration does not seem to improve outcomes in either penetrative or blunt trauma patients. In a study of 150 blunt trauma patients, Doula in 2002 evaluated the benefits of pre-hospital fluid administration, the survival rate of patients. The authors noted that the patients receiving 500 ml of fluid in a pre-hospital setting experienced increased systolic blood pressure and a decrease in intraoperative blood loss. The authors did not identify any benefit from such therapy and recommended that further analysis needs to be concluded if withholding fluid administration would be of benefit. Hott in 2002 and company conducted a retrospective study of 776,000 trauma patients, finding several important mechanisms to worsen the outcomes of trauma patients associated with IV fluid, and suggested including dislodgement of clot formation, diluting of clotting factors, and accelerated hemorrhaging caused by elevated blood pressure. The individual vital signs were also noted, and not good enough endpoints for fluid resuscitation. Other authors have also demonstrated that pre-hospital fluid therapy confers no survival benefit, and aggressive fluid therapy, which was thought to replace lost volume and allow tissue perfusion to establish a hemodynamic state, is lacking in evidence. Looking at the Glue Grant database, literature published by Cassitis in 2013 presented findings on aggressive fluid therapy, which is 5 litres to 15 litres, was associated with developing acute respiratory distress syndrome, surgical site infections, multiple organ system failures, and abdominal compartment syndromes. Despite the widely held belief that pre-hospital venous access placement and fluid resuscitation is standard of care, there is very little data to support this practice. In fact, an increasing amount of data is actually suggesting that it can be quite harmful to a significant number of critically injured patients. Blunt and penetrative trauma can be thought about like a container that has holes in it, holes that require surgical repair. Thus, the more fluid we're pouring into a defective container, the more fluid, now containing red blood cells, which is hemoglobin, will pour out. Should we change this practice for future paramedics and emergency care for pre-hospital settings?
And now we cross over to Patrick, who's on location to talk about hemorrhaging.
Thank you, James. I'm outside of the Hemorrhagic Shock Research Centre to talk about the dangers of fluid therapy during hemorrhaging. As far back as the 1960s to just recently, aggressive fluid therapy during blood loss was the protocol. It was believed that the loss of volume would be managed with the insertion of aggressive fluids. Recent animal studies on pigs and rats show signs opposing the administration of IV fluids during hemorrhaging. Swine are used for the studies of hemorrhagic hypertension and shock because they are very similar hemodynamic responses to humans. The swine was sedated with painkillers so they would feel no pain during the study. They would then bleed the swine in a controlled environment into an uncontrolled hemorrhagic stage and assess a group that would receive fluids and a group that would not. What the researchers found is that the pigs and the rats that would receive fluid therapy died within 30 to 90 minutes of the hemorrhage, whereas the group that did not receive any fluid survived for 120 minutes. In the pre-hospital setting, this appears to support scoop and run strategy. Researchers are debating the best possible protocol for fluid therapy. Increased arterial and venous pressure, dilution of clotting factors, decreased oxygen delivery, and decreased survival rates is a result of fluid therapy during hemorrhaging. Recently, the United Kingdom issued a statement calling for restrained and cautious use of fluid therapy in the pre-hospital setting. Harris explains aggressive fluid therapy increases blood pressure, which increases hydrostatic forces on newly formed clots, dilutes clotting factors and hemoglobin, and reduces body temperature. There is another case study of 2 ambulance services allocated to one of 2 treatment protocols for the pre-hospital use of intravenous fluids in adult trauma patients. Group A were administered fluids at the scene, and Group B was to withhold fluids until arrival at hospital or delay fluids if the hospital is more than 1 hour away. The end result? Group A had a mortality of 10.4% and Group B with a 9.8%, giving it a slight advantage over fluid therapy at the scene. Once again, the scoop and run technique is the researcher's choice. I'll now hand it over to Natalie, who will talk about transportation.
Current literature suggests pre-hospital fluid resuscitation interventions may have detrimental outcomes for patients because they delay time to definitive hospital treatment. Delay at the scene is a consequence of the less than ideal circumstances in which paramedics perform their duties, and is more often than not attributed to the processes of fluid therapy, such as attempting to place a line and failure to gain IV access, especially in patients with profound shock and vasoconstriction. Research published by Smith and colleagues and Harmison and colleagues both demonstrated that delayed transport due to paramedic field interventions increases overall mortality in patients, especially for patients suffering from neurotrauma and hemodynamically unstable penetrating trauma. In fact, it was shown that a percentage of patients may have been salvaged if prompt transport had been instituted. While intravenous line placement and subsequent fluid resuscitation on scene may initially seem beneficial for some patients, the time required to establish an IV may be greater than the time of transport and often outweighs its benefit in urban and suburban settings, where time to hospital is usually 30 minutes. This is the case in trauma. Treatment for trauma is often approached using the golden hour concept. The underlying tenet of this concept is that an injured patient has 60 minutes from the time of the injury to receive definitive care, after which morbidity and mortality is significantly increased. The research by Petchel, Sampellis, and Delton collaboratively demonstrate a significant correlation between reduced pre-hospital times and decreased mortality for trauma patients, especially in patients with severe head injuries, severe thoracic injuries, and intra-abdominal bleeds. These examples, along with the examples previously mentioned, illustrate that the dangers of pre-hospital fluid resuscitation in injured patients does not justify the possible delays in transport time. The primary focus should instead be aligned with Surgeon Donald Tronke's statement that the right patient should be at the right place at the right time, after establishing an effective airway, stabilizing the spine, and controlling external hemorrhage if necessary.
That's all we have time for tonight. Join us next week, where we have an in-depth look at morphine versus fentanyl.